right, welcome everyone to another episode in the JPN video series. Today we're joined by Dr. Moshe Cohn and Rabbi Dr. Shlomo Brody. A little bit of background about our esteemed guests. Dr. Moshe Cohn did his residency in pediatrics at SUNY Downstate. He did his fellowship in pediatric critical care at Northwell and a hospice and palliative care medicine fellowship at Northwell as well. He's certified as a healthcare ethics consultant and serves as a faculty affiliate in the Division of Medical Ethics at the NYU Grossman School of Medicine and sits on multiple working groups and advisory boards. His expertise in dealing with complex chronic conditions and terminal illness. And on a personal note, I can say Dr. Cohn has been very gracious with his time as a consult for the JPN and as a consult for members kind of exploring the world of end-of-life care in a personal capacity. Our next guest is Rabbi Dr. Shlomo Brody. Rabbi Dr. Brody earned his bachelor's at Harvard, his master's in Jewish philosophy at Hebrew University of Jerusalem, his PhD at Bar Ilan University, and his rabbinical ordination from Yeshiva Har Etzion. He's executive director of Amitai, a nonprofit organization dedicated to helping people navigate their healthcare journey in conjunction with their Jewish beliefs. On a personal note, I can say that Amitai is a wonderful resource, and I think that post this video recording, everyone should go check it out, make sure they see what kind of resources are available to physicians and patients. Rabbi Dr. Brody serves as the co-dean of the Tikva Overseas Academy and funding director of the Tikva Overseas Students Institute. He's been a columnist for the Jerusalem Post for over 15 years. This prolific author of many articles applying halacha to contemporary social and ethical dilemmas. His book titled A Guide to the Complex Contemporary Halachic Debates received the 2014 National Book Award, and some of the work has even been cited in Israeli Supreme Court decisions. Thank you, Dr. Cohn and Rabbi Dr. Brody, for sharing your time with us today. We know how precious it is.
Thank you guys so much for having us and hosting this. So I think if we want to introduce sort of how we're like to do this, if you want to launch.
Sure. Yeah, great. No, it's a pleasure to be here, and thank you to the JPN and the whole team there for making this possible. I think what we decided to do that we think is most practical is to present a few case examples, which Dr. Cohn has sort of crafted based on his many years of clinical experience, which we hope will bring out some of the general issues and major positions that people should really be aware of when they think about end-of-life care. Of course, all cases have to be dealt with on an individual level, and there's certainly many other factors that we will cover today. But I hope through some of the case examples and discussion that we have, we'll be able to introduce to people some of the important and really critical distinctions that come up in these issues, and also some of the major positions taken by the poskim on these matters as well. So Dr. Cohn, why don't you get us started, and we'll take it from there.
Great. So just as a tail onto what Rabbi Brody just mentioned, having been teaching medical students and residents for many years, really everything we learn, the way we practice and the way we add to our knowledge is with cases. I think we do that in halacha also, the way we use svarim and various tshuvas. The difference, of course, as Rabbi Brody said, is that there's always detail that's missing. And so this is, I suppose, the usual disclaimer, right? This is not psak halacha. This is meant to provide this framework, but that I know both from the medical side and the halachic side that is sorely missing in our sort of education and upbringing as clinicians, as from clinicians in the healthcare space. And I think that's true on both sides of the pond, as it were. So we'll start with a case that I think is going to be familiar to, or similar to many of us who spend time in an ICU and in medical school. Many of you have. So Martha is a 59-year-old woman with a history of type 2 diabetes and metastatic colon cancer. She's hospitalized for IV antibiotics for the treatment of cellulitis, an infection of her skin. As a consequence of her recent round of chemotherapy, her immune system is compromised and she goes into septic shock. She's treated with broad-spectrum antibiotics, IV fluid resuscitation, and requires vasoactive support, or pressors, and is transferred to the ICU. And at that time, her code status is considered a full code. Overnight, she starts to have trouble breathing and her oxygen saturation drops to 85%. Chest x-ray shows pulmonary edema, and an echocardiogram reveals an ejection fraction of 15%. So she's in heart failure. She started on diuretics and CPAP with supplemental oxygen, which stabilize her. The next day, her whole body is swollen and she stops making urine. The ICU team says she needs dialysis. However, she's still in heart failure and may not tolerate dialysis. However, without it, she will not survive more than a few days. Prior to this hospitalization, Martha's oncologist has said that her life expectancy is 6 to 12 months. Despite her heart and kidney failure, Martha is able to communicate and make decisions for herself. She's adamant that the doctors do everything to keep her alive, as she hopes to attend her daughter's wedding next month.
Okay, great. So this is a really fascinating case, I think a common one. Mark, if you'll make me host right now as a beginning, I'll be able to share a screen as well. And what I want to try to do here is to, I think what this case lays out in relief is two very important, I want to say polar positions, but different positions here or perspectives on these types of cases. Right? You have someone here who clearly has a number of factors that are causing us to foresee that the trajectory here is towards the end of life, but there are certainly interventions here that can be taken in order to extend life. And of course, we also have the factor that we'll get to later on that she wants to continue life in this case and continue treatment and interventions because of the family wedding coming up. Right? So what I want to try to present here is what I think is an important distinction, which is going to be critical in general, right, for laying out how we think about some of these dilemmas. And what I think the important thing to start with is a very fundamental debate, which is, do you do whatever you can to prolong a person's life? Right? In many ways, this is the most important distinction, at least initial distinction, what you get to when you think about end-of-life care and halacha. And there are broad strokes here. We're not getting into all the nuances, and there are important nuances, but there are broad strokes here of two important camps. I have here a picture of Rabbi Eliezer of Oldenburg, I think represents one, but Rav Aaron Soloveitchik is certainly in this camp. Rabbi Jada Ibn Bleich is in this camp, and as we'll see, Rabbi Jacobovitz and others who certainly promote an idea which says that in general, you do whatever you can to prolong a person's life. And the source for this idea comes from the well-known position that we know that in general, not in general, but always, right, we violate Shabbat in order to save a person's life. And so pikuach nefesh, and even Safek pikuach nefesh, is doche Shabbat. And moreover, and this is a critical point to this, we're even doche Shabbat, even in order to save Chaye Shah, right? In other words, we violate Shabbat even to save a moment of life, even to save a few minutes of life, because of the pasuk of V'chai behem, from which Chazal learn V'lo shi'amu behem. So this may indicate to us that there's a real important priority to extending life. Moreover, we have notions in different places, in Tehillim, for example, of saying that a life of suffering, Yasor Yisrael Nikah, God chastised me, V'lamavet lo netanani, anything but death. And anything but death might mean that we do whatever we can to prolong a person's life. And this is precisely what Rabbi Waldenberg says in the shoot, an important response that right below, where he says, מחויבים לעשות כל מאמצים אפילו משום ספק ספק של הצד הגוסס חברו עוד אל החיים כמיעוט דחיים. Right? Now, there's this idea of saying that we have to do all the interventions we can to extend a person's life. I think the chief proponent of this idea, the most articulate proponent of this idea, was the former chief rabbi of England, Rabbi Jacobovitz, who was a pioneer in the field of Jewish medical ethics. And in a number of different writings, here you can see it from 1983, made the claim of saying this idea of saying that we should always do what we can to extend life stems from the belief that Judaism regards every human life as being of infinite value. And here the key becomes that infinity by definition is indivisible, so that any fraction of life, whether 10 years or a minute, whether healthy, crippled, or even unconscious, remains equally infinite in value. And so if you say that every moment of life, even if it's crippled or unconscious, is of equally infinite in value, then your general orientation, of course, is to say that, well, we should always be extending this life of infinite value. And And you can see there's partly a polemical element here going on in society. He's very afraid, not without reason, by the way, as we've seen over the past few decades, that the ebbing light, when we attack this notion of the value of life, we will rob all human beings of the absolute claim to life, make him your relative, and this is very dangerous for a lot of reasons. And so when the issue came of the notion of halachic living wills, the notion of saying that people should fill out, right, a form which says that, well, what do they want? Right? Do they want X, Y, or Z, or don't want X, Y, or Z interventions? Rabbi Jacobovit's attitude on this issue was that living wills is not a halachic concept because the will of a Jew should always be to live. And so, as you can see from his statement here, in this case, it's opposition to Rabbi Tendler. He says this whole notion, there's a case of a living will for an Alzheimer's patient. And Rabbi Tendler says, okay, well, as we're going to see coming up, quality of life begins to get severely impacted. And Rabbi Jacobovit's approach is saying, I think this has no bearing on the value of life, which is absolute and infinite, and certainly not subject to assessment by the patient or anyone else. I believe the whole notion of a living will is alien to Jewish thought. And so this is a very important general orientation to these issues. So if you think back to Martha has interventions here that can be done, that at least the feeling is in this moment, and this always gets a little bit tricky because we do live in a world, and Dr. Cohn, you certainly can comment on this, of medical uncertainty, right? In other words, we think these interventions are going to extend life. Right? We don't always know. We don't always know how they're going to impact. We don't know the side effects. But on the assumption that this is going to extend life, then according to this approach, there's really no question here. Of course, we should be doing those interventions to extend life because every moment of life, even if unconscious, right, would be of infinite value. Now, Rabbi Jacobovitz didn't know this publication, but the truth is already several years beforehand, in the mid-70s, there's a writing of the Steipler Gaon, right, or the great Gedolim of Bnei Brak, who actually questioned this whole notion of saying that we should always do something to prolong a person's life. It's actually quite fascinating. We know now today, based on the research of Dr. Eddie Reichman, Menachem Butler, and others, right, that the tshuva that we're about to see, which is a very, very important statement, was actually written to Rabbi Dr. Abraham Twersky, pioneer in mental health and Jewish thought. And the Steipler writes to Rabbi Twersky as following: concerning the principle that whatever one can do to prolong a person's life, even only for Chayei Shah, it should be done, right? So Rabbi Twersky had asked him about this notion. I think it's probably a common notion that many of us encounter. I certainly see this in my work all the time when I speak to people. And the general thought is, well, Judaism believes that we should always extend life and that every moment of life is infinite value, right? The idea that Rabbi Jacobovitz and others promoted. And so the Steipler Gaon says, I heard this idea in my youth, but I didn't know if it comes from a reliable source. And Sarachian, right, on this issue, because as we're going to see some of these sources later on, in Yoreh De'ah is clearly stated that it's permissible for one to remove an impediment to suffering person's death, if this will prevent severe suffering, as long as one does not move or touch the dying person himself. In other words, as we're going to see, you can take a passive stance in order to prevent a person from continuing a life of suffering. On the contrary, there's a source in which you can derive that it's correct to refrain this situation. In other words, if you're just going to be prolonging the dying process and the suffering process, there is no halachic mandate for this. And in fact, it might be inappropriate, as we're going to see. And so what the Steipler is questioning is saying that this whole idea that we should always do something to prolong a person's life, even for Chayei Shah, right, isn't really accurate in halachic sources. Now, it is true, of course, that we would violate Shabbat in order to save a person's life, even for Chayei Shah. But that doesn't always mean, just because we would violate Shabbat, that doesn't mean that every moment of life is of infinite value, or that we should take actions always to intervene in order to extend Chayei Shah when this is a life of suffering. So this is an important statement of the Steipler. Again, it wasn't published until many years later, but the truth is, as Rav Asher Weiss points out, there are many sources and poskim who take this approach as well. Here's the actual tshuva that he wrote to Rabbi Twersky. And I think there are a couple of very critical sources that people in this camp, Rav Asher Weiss and others, point to that indicate to us that not every moment of life is of infinite value. The two fascinating Gemarot, one or Midrashim, one Midrash, one Gemara. The Gemara in Sota tells us that in the city of Luz, right, it was a city which Sancherib was never able to enter into, and Nebuchadnezzar wasn't able to enter, meaning the conquerors of the evil conquerors of Jewish history will never ever enter there. Even the angel of death was never able to enter in there. So you might say, oh, this is a great place, right? You will never die in this place. But the Gemara doesn't say that. The Gemara says, Elazakanim Shabbat, Bizman Shadata Katzana Lehan. When the elderly there, when it's hard to translate this exactly, but seemingly pointing to when they've sort of become disgusted, right, with their lives. Bizman Shadatan Katzah Lehan. Right? Yotzin Chutz Lechoma Vehnemetim. What would they do in these circumstances? They would leave the city and then they would die. Now, if you think that the will of a Jew is always to live, by what means, right? By what was the mandate for them to be able to allow to leave the city? And yet they do leave the city, which a number of poskim point to is indicating that sometimes not every moment of life is worth living, right? We understand that from here. And that same idea comes from the Medrash, which tells the story of a woman who got very old, and she comes to Rabbi Yossi ben Chalafta, and she says to him, Rebbe, Zakanti Yotamidai, I'm just too old. And it's a denigrated life. I can't eat or drink. I can't taste. And I want to leave this world. Now, according to the approach of the first camp, you'd ask, well, shouldn't the Rabbi Yossi ben Chalafta say to her, no, every moment of life is of infinite value. The will of the Jew is to always live. But instead, Rabbi Yossi ben Chalafta says back to her, well, what mitzvah do you do? And she says, well, I go to shul every morning. And he tells her, don't go to shul for 3 days. And she doesn't go to shul for 3 days. And afterwards, because this zchut is no longer with her, she dies. And so both of these, this Medrash and this Gemara, these Maimer Chazal, admittedly a Gadatot, right, seem to indicate to us that there are times when Tov La'anashim Lamavet, right? It's a person who prefer to die, and Chazal respect that phenomenon. Right? And there are several other Gemarot that point to this as well. We have cases in which various rabbis pray for themselves or others to die, and they're actually pretty explicit about this. I don't want to see all these sources inside, but there's many number of statements, including the Marsha, who in the 16th century just notes that for some people you get to be too old, and they get to the point where right? People don't have a will to live in those moments. But I think the two classic sources that sort of point to this approach come from the story of Rabbi Yehuda Anasi, the death of Rabbi Yehuda Anasi. And here, it's a well-known story, but it's worth seeing here that Rabbi Yehuda Anasi's, and clearly, well, this ends up being the day he's dying, he's clearly quite sick. And the sages don't want him to die, so they decree a fast and beg for divine mercy so that he won't die. And they even say anyone that says Rabbi Yehuda Anasi has died will be stabbed with a sword, right? There's a threat. We all here on this earth have to be pushing and praying to keep him alive. And initially, his servant, the maidservant, sees and says, the malachim above want Rabbi Yehuda Anasi, the people below want him. I want the people below to win, meaning I want God to leave him in this world. But then she sees how he'd have to enter the bathroom and remove his tefillin, and he was suffering apparently from intestinal disease. And so she says, maybe will the God of the upper worlds, I mean the malachim, should win. Meaning she wants him to die. She prays for him to die. And the problem is that she can't stop the chachamim from keep on praying, keeping in this world. And so she takes a jug and she throws it onto the ground. It gets the entire room to be quiet. And before everyone can scream Mazal Tov, what happens? Boom, he dies. Okay? And that Gemara, along with another Medrash, so not really medrash, it's not really a gadata. I mean, it's interesting to claim what is this a gadata or not, is combined with the Gemara in Nedarim, which tells that Rav Dimi would say that a person, it's a terrible thing if you don't visit the ill, because you don't plead for mercy. Lo sheyichya v'lo sheyamut. When you do Bikur Cholim, you know what to pray for a person, whether God should have mercy on them to live or to die. And so Rabbeinu Nisim, the 14th century commentator from Spain, says from here, sometimes it's appropriate to pray for the person to die. And when is this the case? A person is suffering, and two, and he's terminally ill. It's important to understand we have two factors here, both that the person is terminally ill and that they're suffering. And he says, you see this from the Gemara Nedarim, you see this as well from the story of Yehuda Nasi. Sometimes this is appropriate to do. Now, we're not going to get into the whole issue of whether we paskin this way. The Aruch HaShulchan in the beginning of the 20th century does indeed make such a claim. It says, when a person is suffering greatly and they cannot live, we should pray for them to die. And in fact, in the 18th century, the Palchad Yitzchak brings down his encyclopedia a prayer that was composed, which said that we pray for God to return the soul to the person's soul to their maker. But there's all sorts of pushback on this idea. Maybe, we're worried that people that are interested, parties, shouldn't be doing this, like family members. Or maybe, it's an interesting question here, because what does the first camp respond to a lot of these Gemarot? And I think the answer would be, these are all Gadatot. These are all stories, which are interesting stories, but at the end of the day, the Chachamim, not the handmaiden, right, is the one whose position we should follow. And they were praying for Rabbi Yehuda Nasi to live. And moreover, it's interesting to note that while the Ran states we should pray for a person to die, many other Rishonim don't quote this idea, right? So there's a lot of pushback on this. In general, we recommend for people to pray for just have mercy, and God will figure out what that means. But putting that all together, you do have a general approach here from some of these sources, which would indicate that when a person is suffering and they're terminally ill, you have these two factors, and their will that they've expressed is one in which they want to die, as we saw in the earlier cases of the city Piso and Luz, or the woman in the case of Yosef ben Chalafta. Then we have a moment when we say, okay, 8 lamavet, right? As we learn in Kohelet, there's a time for a person to die, and therefore a Sefer Hasidim brings down this idea which says when a person is goses, it's a hard term to define how that applies in our times today, but certainly a person who's not only in terminally ill, but in the dying process, we shouldn't cry out, right, for them at that moment, lest his soul return and he will then suffer affliction. Meaning, if you're just going to call out and it keeps the person alive, but it keeps the person alive and they're just going to live a little bit longer, but life is suffering, why would you do that to someone? Right? And so this is a general approach that is taken not only by the Stipler, but an orientation to these questions by Rav Moshe Feinstein as well, where he says, if prolonging the life of this patient means that he will be maintained in a state of suffering, then it's forbidden to do so. Meaning you should not be doing interventions that is just going to prolong a life of suffering. Or at least, at the very least, you're not obligated to do so. Right? And depending on the circumstances, of course, we have to think this through. And I think this is well summarized by Moshe's son-in-law, Rabbi Moshe David Tendler, and Dr. Fred Rosner, when they wrote as follows: Judaism is concerned about the quality of life, about the mitigation of pain, and the cure of illness wherever possible. If no cure or remission can be achieved, nature may be allowed to take its course. To prolong life is a mitzvah. To prolong dying is not. Okay, now, this is a very important distinction overall, because if you take the approach, which many great poskim do, which says that every moment of life is an infinite value, your entire orientation to end-of-life care questions, including in the case of someone like Martha, is going to be intervene to extend life. But if you take the approach of, let's say, Rav Moshe or the Stipler Gaon or Rabbi Rice or others who quote these sources, then your whole orientation now has a lot of dilemmas, because you have to start asking, well, when are you extending living and when are you just prolonging dying? And that's a very, very important orientation here. Now, what's interesting, Dr. Cohn, in this case, right, is that Martha here, right, says she wants to do interventions because she thinks, based on her doctor's recommendations, that this will prolong, right, her living, and she wants to prolong living here because she wants to make it to her daughter's wedding. So I certainly think that in this case, it's certainly permissible, right, for her to choose the more aggressive path of interventions on the assumption, which is a fair assumption, but there's no guarantees in life, of course, that this will extend her living. But this is, according to one school of thought, an obligation. Of course, she has to do this. Whereas, according to another school of thought, she had choices here to make.
So, it's interesting that the way that the sources kind of go back and forth, whether they're necessarily talking to each other or not, I think in many ways is similar to how we think about things clinically. I think for the students here listening and anybody else as well, and we look at the case, and I'm just going to put it back up again, that here's somebody who, if it were just cut and dry, we just had one issue to deal with, and she needed dialysis and just a few days, and we'd be fine, right? But this is a person who, like many of our patients that we are familiar with, and I know many of you listening are as well, somebody who has multiple medical problems, both chronic and acute, and need to be addressed in the context of the treatments being offered. So that's, of course, the first thing, how we are going to analyze that from a clinical perspective. The second piece of that is that whether the treatment that she's being offered will actually do what we want it to do. As medical professionals, I was certainly taught that when we any test we send, any intervention we do, we are to consider why we're doing it and what the expected outcome is. Even if something as simple as sending a basic blood test, right? What are we looking for? What's the result we're aiming for? What do we want to know? And the same is true here, right? Instead of what I was told not to do, right? What we call reflexive medicine, reflexology, supposed. You need to think about what the consequences are. And in this case, the consequences are unclear. It could be that she'll survive with dialysis and it'll actually help her get her to the next stage of her life, or she may not survive it because of her heart failure. Those layers always need to be thought of, and these both the stories, the Agarata and the Piskei Halacha are important at sort of on the whole, because they address, each one of them may address a different aspect of a case like this, and these are the kinds of cases we actually do see all the time.
Yeah,
yeah,
I think those are great points, and these are cases, and I think that I would say that if you just think in terms of autonomy, right, that people have the right to make decisions here, this becomes a little bit of an easier ethical question because you just give it up to the patient. If you think in terms of life is always worth living, again, it's a little bit easier. I don't mean that easier, it's not weighty, but it's an easier ethical decision to make because we just say, well, the will of the Jews should be to live. When you want to take into account a lot of different variables and factors and sort of different types of equations, moral appeals, if you will, then things get really complicated. And so I think that as sensitive the Jews and as people who are dealing with these questions, if you do take into account a lot of these different variables, it's going to be complicated. I want to also stress before we go to the next case that the first camp I presented is not insensitive to the question of pain and suffering. Right, so Rabbi Waldenberg is very adamant that we should do what we can in order to alleviate pain and suffering. Same thing with Rabbi Bleich. I mean, they make this point in a number of cases. But their belief is, maybe we'll come back to this a little bit later on as well, that while we can address and should address pain and suffering, we should be always doing interventions to keep life going. That is the critical factor.
Yeah, and that is always sort of, I think, the question that then comes up for us. And probably one of the other important takeaways here for this scenario and the way that you outline this, Rabbi Brody, is that not every patient, regardless of the same age, gender, disease, and point in the disease process, is the same. So regardless of even this case that I'm presenting, there are going to be so many other details that come into play And it then becomes our responsibility, both as medical professionals and then certainly rabbinic professionals, to explore and investigate all the details that are going to be relevant for the patient themselves to be part of that decision-making process.
Okay, let's go to the next case, Moshe.
All right, sounds good. I'm going to share my screen and we're going to continue with Martha here. So Martha tolerates placement of the catheter and initiation of dialysis, which is successful in treating her fluid overload, and her kidneys recover enough that she no longer requires it. Her heart failure improves and she slowly recovers from septic shock. And after several weeks in rehab, she's able to return home. And although she remains deconditioned and weak, she's able to attend her daughter's wedding and even dance a little bit. Martha's due to start her next round of chemotherapy and is contacted by her oncologist to set it up. Martha's convinced that it will be too dangerous, given her recent experience in the ICU. On the other hand, her family is pressuring her to continue chemotherapy, telling her that she is strong, she's a fighter, and she will make it through. Martha decides to call a rabbi to ask his advice.
Yeah, so here, this is a really, and of course, this is a familiar case at a lot of different levels. And this is always an interesting dynamic that comes up, of course, is the will of the patients and the desires of the patients, as well as the desires of their family members. And this is something which we try to stress in Amatai when we talk to family members, is that on the one hand, you want to guide and assist your loved one, but they're the ones who are feeling it on their body at this moment. And it's important to respect against some of their choices. But although particularly this is the case, again, if you take this second approach that we mentioned beforehand, I remember we saw Rabbi Jacobowitz said previously, the will, of course, is always to live longer. Now, the assumption in the treatment, the intervention here being given here is that this will actually extend a person's life, right? That this would be the case here. Now we know, and Dr. Cohn, you can comment on this, certainly later on, that that's not always the case. And that many times people, when they choose hospice care or to choose not to intervene, live longer or just as long in hospice care than when they have an aggressive form of treatment. So that's always something to keep in mind when we think about these moral dilemmas. Which is a very, very important factor, which is hard for family members in particular to think about. But let's assume that we think that perhaps this could extend Martha's life. So the question here is about using chemotherapy and whether you can forego such treatment. So here, when we talk about interventions and end of life, I think it's important to distinguish a number of different, or lay out a number of different principles and a number of different types of interventions. Okay, now there's one intervention, of course, which is suicide or assisted suicide, which is sadly more readily available option in Western countries and 10 states in the US where physician-assisted suicide is available, plus DC, and places like Canada where medical assistance in dying is quite prevalent, where it's about 4% of deaths, it looks like right now, and every year annually are the hand of doctors, which is about 13,000 people a year, it looks like right now in Canada. We're still waiting for the 2022 numbers to come out. And that is something which I think Halacha makes quite clear is prohibited. And as with all sympathy for people suffering in pain, such intervention is prohibited. And the reason for that is that there's a general, very important principle, which is known as, which I think is, and I think it's a beautiful analogy that Chazal give to us. And they tell us that it's an important principle that we should not touch a person who is a gosses. And as a general principle, that we believe that we should not be the person who extinguishes the lamp. And I think it's a beautiful analogy because every human being is a light. They're a candle, right? They bring something to the world. It's a unique light to this world. And we shouldn't be the one who's going to extinguish the candle. I mean, the candle might be flickering, but we have a strong belief that humans should not extinguish the candle. Right? And the Aruch HaShulchan, again, beginning of the 20th century, the same Aruch HaShulchan we saw previously stated that it is permissible, and sometimes you should, pray for the terminally ill who are suffering to die. The same Aruch HaShulchan also says that's one thing when it comes to our prayers, but when it comes to our actions, Even though we see the person is suffering greatly, and it will be better for them to die, meaning he's willing to acknowledge it'll be better for them to die. Mikol makom, nonetheless, asur lanu lasot davar lekarev mitato. It is prohibited to do anything that will hasten their death or bring their death sooner. And the reason given is v'ha'olam umla'o shel HaKadosh Baruch Hu v'kach v'tzono yibarach. This, the world belongs to God, and this is his will, meaning human beings. This is an important, I think, theological statement, but also a moral statement, which says that human beings should not be involved in taking out or extinguishing the candle. Now, having said that, and that's a very, very important principle, we also know from our various sources, and we saw some of these sources earlier as well, and this is brought down as well, again, by Rabbi Yehuda HaChassid, who has a oversized influence in some of the psakim here when it comes to end-of-life care. And Rabbi Yehuda HaChassid tells us that one may not prevent a person from dying more quickly. Ein gormim ladam shelo yamut mehera. I mean, don't extend the dying process. And he gives a couple of interesting examples. And these examples cause a lot of confusion here, but let's see what they are. He says, if there is a goses, a person who is in the dying process, and there's a wood chopper that's causing a certain amount of noise that's preventing the soul from departing, you can get rid of the wood chopper. Okay, so this is something that's external, but then you also have a case where he tells us don't place salt on his tongue so that he doesn't die, right? In other words, this is a case where there's a belief that salt will keep the person alive. Don't put salt on his tongue so that he doesn't die, right? We should allow natural death at this point. And similarly says, and if a person were a goses and says, I can't die unless I move somewhere else, you don't move him. Right? This is a general principle. Again, we do not want to extinguish the candle. So we don't want to hasten someone's dying, but we don't want to prolong their dying process as well. And the Shulchan Aruch, followed by the Ramah, bring this down the Halacha. We have it here in Hebrew, but let's see it in English. And they say anyone who hastens his death is considered a murderer, Rego says. And the Ramah adds, don't cause a dying person to die quickly. And it gives these examples. For example, a person who is a goses for a long time is unable to separate from the world. It is forbidden to remove the cushion or the pillow from underneath him, as some wish to do, believing that certain bird feathers are delaying his death. Right, so you can't take out the pillows. You think that the pillows, right, are delaying the death, the bird feather, delaying the death. You can't remove the pillow, and you can't move the person from place to place. However, if there is something which is is preventing the soul from departing, for example, the wood chopper or the salt on the tongue, you are allowed to move the wood chopper and you're allowed to remove the salt on the tongue, because this is considered, right, ein bazet maseh klau. It's not an action. Ele shemisir hamonea. You're just removing the impediment. Now, if you look in the summary here, you'll see on the right side, you can't cause a person to die faster, which means don't remove the pillows, don't move them. And then there's another example, don't put the keys of the synagogue under his head, which was believed somehow to cause the person to leave this world. That's forbidden. But you can remove the impediment. And the impediment, the Mesir Monea, includes the wood chopper, and you can remove the salt on the person's tongue. Now, this is, on the one hand, very detailed. On the other hand, as many of already the commentators of Shulchan Aruch ask, it's not exactly clear what the distinctions are. I mean, why are you allowed to remove the salt on the person's tongue? Not just you don't have to put the salt on the person's tongue, but you're allowed to remove the salt from the person's tongue, but you're not allowed to remove the feathers under the pillow. Moreover, there's a question of exactly how is this all working? And how does this all, relate to things like pressors or ventilators, or other things like that today? So this causes a whole slew of discussion in the poskim on these issues. And as you can imagine, as you understand, right? So it's like the Taz, for example, says, listen, you can't take out the salt. Doesn't make any sense. That's the type of intervention that's going to hasten the person's death. But others believe that as long as you don't remove the person, you can remove the salt. right? And then you get into an interesting position of the Shiltei Giborim, who tells us that something which is preventing the departure, that you're allowed to remove because you're not snuffing out the candle. But if you're going to move them around, no, that's snuffing out the candle. Right? And so, as you understand, this leads to a lot of discussion. And we saw earlier the Stipler quoted the position of the Beit Lechem Yehuda. And the Beit Lechem Yehuda says, listen, you should remove the salt. And the part of the reason why you should remove the salt is that it shouldn't belong there in the first place. Okay? And this we pointed to is to point to the fact that we don't want to extend a life of suffering. So a lot of this gets to a big discussion about exactly can we figure out based on these examples of the feather and the keys of the shoal and the wood chopper and the salt, how does this relate to contemporary medicine? A lot of big discussion about this. And I want to show you what I think are some key principles that get brought out by the poskim here, even though, again, you could argue about how this is the right way to read the Rishonim on this issue. So one of the important poskim in Israel, Chaim David Levi, former Sephardic chief rabbi of Tel Aviv, uses the case of the salt to address the issue of the ventilator. And his take on the salt, following what his interpretation of the Beit Lechem Yehuda was, is that you originally put the salt on there when you thought that there is some cure for the person's illness. And that's why you put the salt on there, to extend the life. But once you see that there's a gosses and all the salt is doing is prolonging the suffering, then you're allowed to remove the salt. And so Rav Chaim David Levi says the same thing should be true when it comes to a ventilator. Right? When a ventilator, you put it on because you hoped it was going to be a bridge to somewhere. But when it turns out that the ventilator ends up being a bridge to nowhere, and that the ventilator is just prolonging a dying process, not only is it mutter to remove the ventilator, but in fact, you're obligated, right? It's forbidden to keep a person on a respirator or ventilator in such a case, because all you're doing by keeping them on there is extending the life of somebody. And the Mishnah Halachot, actually, Renasha Klein says something similar, although he's nervous that when you extubate, you're going to end up moving the body, and therefore he says you should just remove the central line, but you shouldn't actually take it out of the patient itself because that will move the body. But this is a minority position in the poskim, and the vast majority of poskim, following Ritzitz Eliezer, Moshe Feinstein, and others, believe that there is a problem with extubation when it will lead to immediate death. Right? And so Rav Moshe lays out a very important principle and says it is forbidden to remove the respirator for fear that he will be alive and this will kill him. Okay, so Rav Moshe is saying that this is a problematic because you're doing something that is proactive, kum ve'aseh, and he doesn't see the ventilator as just an external impediment. He sees it as something which is actively, it's like removing the feathers, the pillow underneath a person's head. That's proactive. That will lead to immediate death. That is problematic. Now, what Rav Moshe does say, and this is quite interesting, and this is a mainstream Orthodox position, by the way, right, which understands that on the assumption, which we can discuss at another time perhaps, but on the assumption that extubation will lead or cause immediate or soon afterwards death, then it is forbidden to extubate in such circumstances. However, Rav Moshe points out, and this is a little bit dated, but remember the old days, you didn't have central lines, and so oxygen would be provided with tanks. And so he'd say that, listen, if you have to service the oxygen tanks, right, and it's where the tanks are, it's being piped in here, right, from the tanks, or if you have to, for whatever reason, remove it, so then you can test and see at that point, you don't have to re-intubate at that moment. This is a very important distinction because on the one hand, there's a very important statement here which says that withdrawing interventions when it will lead to immediate death, following the model of removing the pillow of under the person's head is problematic. That is problematic. We're afraid that we're snuffing out the candle. However, if it's already out, right, if you had to extubate for various reasons anyway, right, you had to remove the oxygen or stop the tank or the tank runs out anyway, this would not be a problem to withhold intervention in this case. And this is a very important distinction, because while when it comes to oxygen and when it comes to ventilator today, because of central lines, more or less, although even there it's a little bit tricky, but more or less this can be continuous, the vast majority of interventions today are not continuous. The vast majority of medical interventions today are known as cyclical or intermittent. And this becomes a huge opening, if you will. And let's think about Martha's case now, going back to Martha, when it comes to questions of types of treatments which are not continuous but are intermittent or cyclical. And when Israel had to deal with this issue in the terminally ill patient law in the beginning in 2005, 2006, 2008, and the committee was set up by Professor Avram Steinberg, who's a member of Immatai's rabbinic board and very, very, very distinguished medical ethicist. So the committee came up and said, listen, treatments, interventions, which are cyclical or intermittent, can be stopped in between cycles, in between treatments. And so if you take a look, there's actually a very important number of interventions which we can withhold or at least forego, if you will, depending on the circumstances, how you think about this, including surgery or radiation, or pressors, and even cyclical interventions such as dialysis and chemotherapy. And we're going to get into a little bit of antibiotics and IV coming up as well. But this is a very important distinction, because once you say that it is a problem when you are withdrawing care in a way that will cause the candle to be snuffed out, but it's not a problem to withhold placing the salt on the tongue, right? It's not a problem to withhold certain interventions when a person is terminally ill and suffering. That opens the door for foregoing many interventions. And so in Martha's case, according to this line of thought, right, which I think is a very strong line of thought, which is sort of taken, I'd say, the mainstream, although other lines of thought certainly exist as well. This allows Martha to make that choice. So Martha can say, I would like to forego this treatment, which in my mind is not going to extend my life in a meaningful way. Dr. Cohn.
So I love the way you put that, and how, what all these considerations that the poskim are really talking about, I think, are in reality quite subjective, right? When somebody, it gets to the person themselves is going through something in a way that at some point has to be relayed both to their family, to maybe their spouse, and to a Rav, in order to arrive at some appropriate guidance that's going to vary based on their personal medical condition, mental state. I think the other thing that's worth pointing out here that I think is important in the clinical setting is the use of language. I think the poskim are very sensitive to the concept of removing something, and I think that is both because it has that tangible issue of snuffing out the candle, but also because of the optics of it, in that you're taking something away, and it feels that way. And I've seen that over and over again in my patients and their families. And so even the idea of withdrawal of something, I think doesn't sound good. Whereas a patient deciding to forego something and saying, you know what, I don't want this. I wouldn't want this. I never wanted this. I think is a choice rather than someone taking something away from them. And I think that's important in a way that we as medical professionals, and I think also Rabbanim, but the way we speak to patients and people who come to us, because we need to make sure we're using the language that is going to resonate. You're making a choice to go down a certain path rather than to just take something away. Even if we all agree that it's not necessary, it still feels like, we know psychologically it feels much worse when you take something away from somebody than if you just don't offer something. And then the last little point here is for my little soapbox in the palliative care world, we've largely tried to move away from the terminology of withdrawal of care. We like to say to people, we always care. We never stop caring, and we always provide care. We may provide a different type of care than we were providing before, but we never stop caring.
That's a very important point to make. And if I slipped into the care, that was a mistake. But you're absolutely right? It's always withdrawing or withholding interventions. Care should never be withheld. And that's a crucial point to make. I fully agree with that.
All right, so I think we'll have time for the last case, which is shorter, and we can hopefully get to some questions. So Jacob is an 88-year-old man with advanced Alzheimer's dementia. He has suffered rapid cognitive decline over the past 12 months, and he has lost interest in eating or drinking, but will take small amounts of pureed food if offered. Last month, he was hospitalized for pneumonia, and it was determined that he had difficulty swallowing and often aspirates his saliva as well as food. In the past few weeks, he coughs almost every time he tries to swallow food, but most of the time refuses to open his mouth at all. His family is worried that he will starve to death without food or hydration and asks Jacob's doctor about placing a feeding tube. The doctor explains that the tube may not prolong his life as he will continue to aspirate. The family consults with their Rav for guidance.
So here, this is unfortunately a very, very common dilemma. And here there are two real fundamental questions. First of all, just on medical level, you have to ask what type of interventions here are actually going to be most successful in extending life, as well as preserving some form of comfort. Because the old intuition was, that you always have to provide some form of artificial nutrition or hydration. But many times, even that's the instinct, this might be medically counter-indicated. And this is precisely, I think, what the doctor is trying to hint to, but to explain in this case. You think that, artificial, whether it's a peg or something else that's going to be used as some form of intervention is going to extend a person's life. Not only may not extend a person's life, it might actually shorten the person's life because of infections or aspiration, whatever it might be. So the first question always has to be here is, on a clinical assessment, right? How do we see this type of medical intervention? Is this actually going to be beneficial or not? On the assumption that this would be somewhat beneficial, right? This could extend the person's life. Here you get into the question that we've seen before, that we sort of established principle of foregoing interventions. That's permissible, but the question becomes, are there some interventions which are simply not permissible to withhold? And here you get to some important statements of the poskim that really came out in the 90s in many ways. Here we have Rabbi Shlomo Zalman Auerbach, who's talking about, and he again is in the camp of the Steipler God or Moshe Feinstein, who feels that a person can forego certain interventions, whether it's surgery or an amputation, whatever it might be. But he stated here that it is always required to give the patient food and oxygen, even against his will. In other words, you're allowed to refrain from certain other interventions or medications, but you always have to provide food and oxygen. And here as well, Shlomo Zalman, along with Rabbi Yashiv, Rabbi Buzder, of Karlitz, Zatzal, all these great Gdolim. So they wrote a sort of a Kol Koreh in the 90s in which they declared, right, that certain types of withholding nutrients, certain types of medical treatments cannot be withheld because those will hasten the demise of the terminal patient. And in their list, they include IV feeding or fluids or morphine or antibiotics and insulin injections. Okay, now, there is a little bit of pushback on some of this list of exactly what they said, but this is all on the assumption, again, that this is medically indicated. Again, if it's medically counter-indicated, putting a IV and giving a person fluids when the body can't handle it is just a terrible thing for a person to do. That said, there is another school of thought which doesn't see this as a natural. I mean, the part of the idea here is that this is a natural necessity and not a medical treatment. And Moshe Feinstein also discusses this as well, where the assumption is that providing nutrition is always going to be beneficial. And Moshe's language here is actually very important because Moshe seems to think that oxygen, not providing oxygen, is always, or nutrition is always going to cause the person to feel worse or to feel some form of discomfort. And that's why you cannot withhold such an intervention, right? He thinks this is a natural necessity. Now, more recently, again, you see a little bit of pushback on this idea, and it's partly because of from medical experience, we see that sometimes this is medically counterindicated. But Rav Hershel Schachter of Mordechai Willig of Yeshiva University have argued and said, listen, at some points, this is just another type of medical intervention. And so when it comes to foregoing, when it comes to withholding certain types of interventions, if at some point we understand that this is just a bridge to nowhere, that this is just going to prolong the dying process, and a dying process which includes some form of suffering, then they state no new therapies such as oxygen or artificial hydration, nutrition need be administered. The primary goal of care should be maintaining the comfort of the patient. Okay. Now, this is a very important ruling because this opens the door for withholding all sorts of interventions at the end of life. And, you know, the PEG, I think, in some ways, in this case, comes up, and others is really sort of the classic case here. Do you insert the PEG? But I also want to always stress to people that even if you think that, halachically speaking, you should insert the PEG, these types of interventions have a lot of potential side effects, including infections and others. And so before you ask the halacha question and get this very important machloket, you have to really ask if this is medically indicated.
So the issue there, and it's a great final point that you're making, Rabbi Brody, especially in light of, I think, how many of us who are raised or have a background in Torah and Orthodox Judaism then end up in medicine, and what we have in our brains is always like v'chai b'hem, and that's always true. And I love how we are sort of qualifying that further. But in particular here in a case like this, where I often point out to families, and those of us, anybody watching who is in palliative care or in pediatrics knows, the first question a family asks when they get to the hospital, doesn't matter how sick somebody is when can they eat? When can we feed them? Because it's for those of us who are not, if you're not in the medical profession, how do we care for our loved ones? We feed them. We invite people over, we feed them. And so this issue of not feeding somebody, it's painful even to a family member to the idea that we're not doing that. On the other hand, as you said, it's really so much how medically relevant and necessary or beneficial it is. And the side effects that are there are very, very important. I also appreciate certainly the way Rav Moshe's words. I so often, you quote a pasuk, you quote a posek, you quote the first half and not the second half. And so Rav Moshe, he says, well, you have to provide nutrition, hydration, and oxygen. Why? Because it's a natural need. But the other half is, yes, because the assumption is it's going to help them. And in many cases, medically, we know that in many cases it is not going to help them and may actually harm them. Whether it's high levels of oxygen in a neonate in the neonatal ICU, or whether it's adding nutrition in either a PEG or even with TPN in a vein to somebody who's older and at the end of life. So I think knowing what the goals are of each intervention is important. And then the last thing I think for us as medical professionals, I remember when I was in yeshiva, I got some advice from Rabbi Dr. Howie Apfel, and many of you might know him from YU and from Columbia, pediatric cardiologist. And I was talking about my career planning. This is a long time ago, and I was worried that I wasn't gonna have enough time to learn when I was in training. And he said, no. He said, your job, your Torah is medicine. But right now, for however many years you're going to spend doing this, you're obligated to know the ins and outs of every little thing that you're treating. So for us at the bedside of any patients like this, we have to know the medical pros and cons, the science as best we can, and all the details of any procedure that is suggested, above and beyond the halacha. The halacha, we are not the halachists, we are not the poskim, but we have to be able to inform them and have that knowledge and be the experts. And if we don't know, we need to know who to talk to on the medical side about that as well, and to always be curious to make sure that we know the information we're providing.
Yeah, and sometimes, just even spoon feeding can sometimes get the job done as well. It's also a very satisfactory way of sort of caring for people as well. And those are very important points you're making, Dr. Cohn.
Thank you, Rabbi Brody. Mark, I'm gonna, I think, hand it off to you.
Sure. Thank you both so much for such an informative session. We're going to open it up to questions if anyone has any. You can either put it in the chat or you can unmute yourself, show your video if you're so brave. And if not, then I have a question or two, and then we'll end off. I think there was one post in the chat. I don't know the context of it, because I think it was at the moment that something was said. Does that include ordering certain medications? Perhaps that person can clarify what they meant by that question.
I think my impression is that that it was about related to the issue of agoses and potentially using medications for comfort. I mean, for that are at symptoms, whether it's benzodiazepines, right? So for anxiety, or for dyspnea, or opioids, when that happens. And if someone is considered agoses, and whoever is defining that, can one use medications that are aimed at relieving some sort of suffering, with the concern potentially they may have side effects, that there are beliefs out there that those side effects may hasten death.
Yeah, so I mean, that's a critical question to clarify, but in general, pain needs to be addressed, right? Delirium, agitation, right? All these things that Sarah's raising, these need to be addressed. I mean, these are symptoms that are very serious. And both schools of thought that I mentioned from the beginning are very adamant about this point, right? Pain is something which we cannot ignore. And pain physiologically can shorten life, but pain also is something which we just care a lot about. And the Tzitz Eliezer himself and many others following that lead talk about this idea of the importance of saying, well, we just have to address the pain. And they raise the possibility, and I know, Dr. Cohn, you have feelings about this, about understanding the side effects, but they raise the possibility that even if it would have the side effect, not immediate and not inevitable, right, but a possible side effect of actually causing a person to die a bit earlier, nonetheless, we still have to address the pain. But on a clinical level, I think it's important to understand, and Dr. Cohn, I invite you here to comment on that, about the reality, because there's a lot of myths and misunderstandings about this.
And just briefly, and this is something I think that hopefully with the JPN will present again in longer form. But the bottom line is that somehow with medications like this that have certain side effects that people are worried might hasten death, we in the medical profession have done a disservice by being a little too hands off and loosey-goosey about it, meaning that, you know, in the ICU, we're focused on microdosing of all sorts of different medications. And then in all of a sudden, someone is in pain end of life. Okay, well, we're using standard dosing and not paying attention to the effect those doses have on the patient. And if anything, you know, the opposite should be true, or at least it should be equivalent. If someone is suffering, then we should treat that suffering, but treat it appropriately and use appropriate dosing. I mean, I'm also an ICU doctor, but the way I was trained and the way I believe in as things in accordance with certainly the way you presented in Halacha is that you treat pain like you would treat any other illness. In fact, my Rebbe, Rabbi Tendler, Zechron Livracha, I remember asking him that question about, you know, what do I do even on Shabbos, right? So I have a patient who I know is dying, but they're calling me and they want me to come in to see them. I have to examine them to see about treating their pain. He said, and the question is, can I even violate Shabbos for that? He said, of course. Why? Because they're a chol sheyesh bo sakana, and my job is to take care of them. My job is to treat them. It's still treatment, and that's the difference. And back to what I said about using words. When we are treating pain, we're treating symptoms, we are providing treatment. And if it's appropriate treatment, then we are not hastening death.
Mark, you want to ask your questions?
Yeah, just to clarify, this entire conversation that we're having regarding being able to, you know, withhold certain aspects of care, I imagine this is within the context of someone who is chayesha. And maybe you can clarify that. And what do we do when there's no certainty that someone is in fact a chayesha?
So I think this is really in many ways the next frontier. I mean, it's obviously something which has been addressed already, but it's in many ways the next frontier of the issues of end-of-life care and halacha. Because let's take an example in Israel. The terminally ill law in Israel only addressed cases in which a person has a prognosis of 6 months or less to live, with the thought being that twofold. One is that we're not really sure how accurate the predictions are when people think beyond 6 months, and because that's a length of time that's recognized in halacha. So it worked out well for both the doctors and the rabbis to determine the law in that way. But as we all recognize, there are many times when, while it may be a little bit less certain, you have cases where you have acute critical illness, you have a number of different factors, comorbidities, whatever it might be, that are going to give us a sense of this person, the trajectory here is not of a long-term life expectancy. Maybe it's 12 months, maybe it's 18 months, maybe it's 3 weeks, right? We don't know. And in this regard, Rav Willig and Rav Schechter, in the article I referenced earlier, following up on the article of Rabbi Dr. Judah Goldberg. Rabbi Goldberg is a ER doctor in both Florida and Jerusalem. He's also Rebbe in MMY and member of the Emetai's Rabbinic Board. So he's trying to advance this conversation, article, and tradition, where he said that the same principles have to also apply when it comes to acute critical illness, which is not necessarily a case of terminal illness. We have a number of different comorbidities, a number of different factors here at play, but we don't know. And the question becomes, can you in those situations elect to sign a DNR or DNI? Or can you say at this point we can forego treatment? And here, this is a major dividing line in some ways, because Rav Willig and Rav Schechter are certainly willing to entertain that possibility of foregoing interventions in those cases. Other poskim don't believe that's correct, and others push to try to get us greater amount of medical certainty. Right? Then as they want to say, let's try to push this a little bit stronger and determine if this is terminal in some form or another. And so the question you should raise, Mark, is how do you define chayesha? Is chayesha a matter of months? Is it 6 months? Is it a year, according to some classical sources? Could it even go beyond that? This is a major question which we're really going to have to address because of the nature of healthcare today, in which we can keep people theoretically at least going for quite a long time, but the question becomes towards what purpose?
I think I would clarify. I'll add to that by saying that for Mark, for your question, and I think this comes up for any of us as soon as we start learning the basics of the halacha here, is that I always want to dig further into what do you mean by chayesha? Chayesha has a halachic connotation, but from a medical perspective, that can mean many different things, as Rabbi Brody was saying. But in addition, what matters also, I think, medically is does that chayesha have a particular value? In other words, is it important for this person to survive for a short period of time as a bridge to somewhere, as a bridge to something that will potentially reverse the disease process? Or is it simply for the purpose of keeping a patient alive longer because of their particular posake? I would argue, and I've sort of learned this, I would say, the hard way, is that unfortunately, as much as we like to think that we have the answers, and we want to try really to have these conversations we're having now in order for us to be prepared, at the end of the day, families are going to make the decisions they're going to make. And they often make decisions that we think we in the medical profession are incorrect. We think, well, how could they do this? They're suffering, or on the other way around, how could they, sign a DNR? But we can treat them. And I've been on both sides of that myself. And in the end of the day, they'll make the decision they make. And I like to say it, most of the time, it's going to turn out for the best. It's going to turn out for whichever way the family decided something drove them in that direction. And it's in the aftermath, we sort of may analyze it, but whatever decision they make, that has to be the right decision for them. We do our best to prepare them and to prepare them in as positive a way as possible. But the idea of chayesha, I think, alone in the abstract doesn't work and medically either.
Understood. I think any other questions would really be for another session, and I think you kind of touched upon a lot of things. So I think this is a good point of break, unless anyone has any other questions. But thank you both so much for joining us today and giving such an informative talk.
Thank you. Thank you so much for this opportunity.
Yeah, saying thank you so much for hosting, and we'll make sure to share the Amatai website in the group chat offline, and so that anyone can reach out to Rabbi Brody, and of course,
I put my email here. If anyone has any follow-up questions as well, they're welcome to reach me at brody@amatai.org.
excellent.
All right. Thank you, and everyone should have a great rest of their day.
Be well.
Bye-bye.